Okay, good morning, everybody. If you haven't already, you can fill out your K and W on our KWL. Excuse me. And if you would join us on the Menti, if you could give me a reaction. I think all I have are thumbs up on this one. I'm sorry. No fun. What was it? It's heart, thumbs up, thumbs down, question and cat. Yeah, I know the cat's popular. Um, so once you get logged in, let's go through here. There's a couple of reasons. I mean, not a couple reasons. There are reasons why I think that skin is really important. Skin breakdown is really easy. It can be very easy to happen for patients, and it happens pretty quickly. You can be doing all these interventions for patients and doing all these other things to really keep them healthy. But if we forget about skin, if we forget about all of our interventions to help protect their skin from injury, patients can develop pressure ulcers or wounds fairly quickly. So it's really important. Also, we'll talk about it a little bit more. Your pay is actually related to patients' skin health, meaning that if you have somebody, let's say you work at the hospital, and somebody comes into your facility and they have an existing pressure injury, maybe on their coccyx, right? If we don't document that this was an existing wound there, they already came in with it, then Medicare and Medicaid will say, well, actually, then if you didn't document they came in with it, then you guys now own that. You caused that, even though we didn't. So it's really important with our assessments, we're assessing our patients, because if we are causing those wounds, your facilities actually won't get as much reimbursement from Medicare and Medicaid, which means less money in your facilities, which means less money ultimately in your pockets with your pay. So that's just a big way. Sometimes I'll talk about how to save money in the healthcare system. And it's not just about so we can make money for these corporations, but really it's about so that money can be now hopefully equitably distributed, to people's pay or for other things that can help with patients, not just to, go in corporate pockets. Okay. Small little stand aside. Are we in? We're kind of in. Okay, go ahead and join if you can. Oh, helps if I turn this on. All right, so let's talk about skin first. There we go. All right, so this one is chapter 54. So we're going to talk about pressure injuries. That's where we focus a lot about the first part of this talk today. So pressure injuries is whenever you have pressure against the skin. So think about for a second where you're sitting right now. Oh, a code.
Yeah.
Yeah. Will somebody read me the code and I'll write it down?
2503 8427.
That's good? Okay. So think about where you guys are sitting right now. Where are some points of pressure that you have on your body? Probably your coccyx. What about your feet? So he's got his feet kind of kicked out. So maybe some pressure on your heels, right? Like anywhere where your body is touching and pushing on something. Maybe you've got your elbows got some pressure right now. My glasses, or if you're wearing glasses, behind your ears, you might have a little bit of pressure. Anywhere where something is touching you and kind of pushing in a little bit, that has a potential to form a pressure injury. If you've ever had glasses that don't fit very good, you have been like, man, this is like killing me. It's hurting, right? We have this sensation and the ability to say, that doesn't feel good. I don't want that. I'm going to remove that. We have patients who don't either have the sensation to notice when something is happening or the ability to say something about it. So that can cause, injury to start happening when you don't remove it. So etiology, I'm talking about pressure here. We also have friction, right? Maybe sometimes if you notice you're cleaning somebody's skin, and especially we talked about in older adults, their skin gets so thin, they lose that subcutaneous fat, and you can actually have kind of a tear or like skin tears from the friction on their skin. And then I also think about shear. Anybody remember from reading what shearing forces are? Yeah, it's like dragging or the opposite pulling. I think about our patients who are sitting up, in bed, we pull them up in bed because we want them upright for their breakfast or lunch. And then they kind of slowly sag back down. And so when this is the patient, they're sitting up here and their body, the weight is pulling down while the bed is trying to pull them up. And you can actually have shearing that occurs where you kind of rip the tissue away from the body a little bit. Very painful. All right, so moving on, what are some risk factors for pressure injury? I started talking about it a little bit, but I want you guys to go ahead and type in, or if you haven't logged in, just think in your head, what are some risk factors for pressure injury? These are good answers, you guys. See a lot of immobility, decreased cognition, your age, dehydration, incontinence, immobility, their circulation. So great answers. These are all correct. So risk factors, like you said, immobility. If you can't move that piece that, if your heel is digging into the bed and you can't move your heel to relieve that pressure, you might form a pressure injury on your heel. You might have impaired circulation, so you're not getting all the blood flow that you need there. You can't feel that, like we talk about our diabetic patients, right? We teach them to look at your feet every night because maybe they get a new pair of shoes or maybe they get a pebble in your shoe. Anybody cannot stand any pebbles in their shoe? I'm constantly stopping on walks because I might have a grain of sand in my shoe. I cannot stand it. But our diabetic patients might have loss of sensation and they are walking around all day with that and it can end up causing a little wound. They don't feel it. And then if they don't check their feet, that can go on and on for weeks until it develops to this very large wound, the sore that they can't see because it's on the bottom of their feet. So we teach our diabetic patients at the end of every day, take your shoes and socks off, look at your feet. Make sure there's no pressure, no injury, nothing that went on. Our elderly, or the very thin or very obese. So on the opposite end of the spectrum, you're very thin, you don't have any cushioning. You're very large, you're very heavy, and you're causing a lot more pressure. So what are some ways that we help prevent pressure injuries? You guys are good. These are great responses, you guys. Turning, moving, repositioning. I really like you're including things like nutrition, increasing protein, patient education, right? Because we can encourage our patients to turn and move and do all these things, but if they don't understand the why, they might not be doing that. Keeping them clean, keeping them dry. All right, so question, I see a lot of turning patient every 2 hours, that's our evidence-based practice we follow, that we want to move or reposition our patients every 2 hours. How often do we encourage our patients to reposition if we can? Every 15 minutes. If they can, we tell patients, go ahead and reposition every 15 minutes. Now, that doesn't mean we're saying lay on one side and then 15 minutes lay on the other side. It just means shift a little bit, move, because all those pressure points, every 2 hours, that's going to help hopefully keep big pressure injuries. But overall health, if we can just shift a little bit from time to time. You guys do it all the time, right? In class, you're like, oh, I got to cross my legs this way. Now I got to cross my legs this way. I want to move this way because we're redistributing all that pressure. And patients sometimes forget about that when they're sick and they don't feel good. So we want to remind them every 15 minutes, just move around a little bit if you can. We also want to use a valid assessment tool like the Braden scale. Now, have you guys used the Braden scale in lab? A little bit? Okay, we're going to use it later today and go over it together because unless a new scale comes out, this is what we're gonna be using in our clinical practice for a while. I've been using it for decades and it's a pretty good tool. Cleanse and dry the skin every day. You guys mentioned, somebody mentioned about keeping the skin dry, super important. And we're gonna have practice changes that happen to help promote this. When I was a nursing assistant, we had those big pads that are like the fabric and they're really thick because we were like, we just wanna like suck all that moisture away from the patient. But then the patient ended up being in this wet pad like for a long time. We thought it was great because it would suck up a lot of pee. Unfortunately, it kind of held some of that moisture against the patients. So now, usually what we'll see in most places are those, like the paper and plastic, pads, because
The doggy training pad.
like a doggy training pad, because they wick the moisture away, but they have a barrier that keeps it from touching the skin. That's usually why they don't like patients to be in diapers or Depends, whatever you want to call them, because Depends aren't so good at, they're good at catching the urine, but they also kind of hold it closer to the skin, where it's better if the patient could just pee honestly on a pad, because that pad will wick the moisture away and not hold that moisture against their skin. So that's a big change from when I was in a CNA. So there are going to be things that change and that we learn, and we want to make sure we're keeping up with practice to help keep our patients safe. We want to moisturize daily, right? If our skin gets dry, it can crack, it can get excoriated. We want to clean incontinence promptly, right? If we're holding a baby, if the baby farts, right, we're like, oh, we probably need to change their diaper. Same thing with adults, right? We don't want them sitting in their stool or their urine because those things are caustic to the skin. They're going to cause some breakdown. So unfortunately, there's some patients who you're going to feel like you're in there all the time changing. Fortunately, now we do have things like PureWicks, which if you guys use PureWicks in lab, start looking at them a little bit. Do you guys know what I'm talking about? Oh, gotcha. Yeah, so they're men or female. They're really effective. You guys know I'm on call. I work per diem for St. Clair in the surgery recovery room. I actually got called in earlier this week in the evening, and I had a patient who really had to pee, but she just woke up from surgery. So like she just rolled into recovery. She's like, I really got to pee. And I was like, I hear you, girlfriend. You're not getting up right now. You know, like she was just loopy as all get up. She was gonna fall. So I talked to her about the PureWick, sorry. Sometimes in nursing, they call them cooter canoes. Probably not the best term. That was all I could think of for a minute. So the PureWick, she didn't want it at first, and then she did. She was like, I guess, and it worked beautifully. Like I put a pad underneath her, and the PureWick was able to suck up all of the pee and get it right into the canister. It was lovely. I will say you do have to make sure you put them in correctly, which means for a lady, you do have to spread the labia and then put them right kind of against where your urethral opening in. And then the labia is kind of like hot dog buns. It kind of closes over the hot dog. And it worked so well. They also have them for men where it kind of wraps around. But that's been a great invention for patients because we know indwelling urinary catheters, right, that are actually invasive and go inside the bladder, they can cause urinary tract infections. So this is another way we can wick away moisture without giving them the risk of having the UTI. Okay, moisture barrier. If we know somebody's incontinent, let's put on some moisture barrier on them. That just helps to provide a little bit of, you know, something between them and the skin, or them and the moisture, them and the moisture, something between. And then don't massage reddened areas or bony prominences. Some people think, oh, well, like their elbows got kind of red because they were sitting and pushing against the bed. Really, we don't want to massage that area. We want to just relieve the pressure on that. Yeah.
A lot of the homework had answers that would say massage the bony.
Yeah.
Like as the correct answer?
So it would be like, do not massage, like massage it, so it was kind of confusing.
Gotcha.
Yeah, I mean, I know the answers do not, but it just would be confusing.
Yeah, I'll take a look on the Davis ones. Okay. Thank you. I'll take a look and see if I can. Okay. Thank you for bringing it up. Typically, we don't want to massage if it's reddened, especially, because that's telling us there's already some sort of damage or potential injury that's happening. We do, like I said, we want them to shift their weight every 15 minutes, not big movements, just little shifts. And if they can't really move themselves very well, every 2 hours, we're gonna be moving them and changing our position. Heels are a really big one. We tend to forget about heels. They can kind of just sit there in the bed, and especially, like, think about somebody who's laying in a bed, right? They're here in front of me. I'm doing my assessment, I'm turning, repositioning. Oftentimes we can forget to look at heels. There's a unit I worked on, where's Chris? On Metella years ago. We had part of our committee that worked there. We were like, you know what, we are having a hard time looking at heels. Because if you think about it, you're like having to lift the leg up. A lot of times you're getting down. It's really hard to see. It's dark. And so one of our nurses was like, why don't we just get mirrors? And so we brought it to our management and they purchased a bunch of mirrors so that all we had to do was lift the heel up, look underneath. It made it as easy as that, but we were able to look at each other's heels so much easier. It increased the compliance of the nurses being able to look at it. So think about, there's innovative ways that we can go through that. If you guys bring this to your managers, bring this to your committees where you're working at, there, you know, a lot of times people really appreciate that. A lot of our managers maybe don't work in like directly with the patients all the time anymore. And so they're not as in tune with what the needs are. So when you guys are in tune, bring those needs to the people above you, because you know better than they do what the patients need. Okay, let's keep going. A pressure reducing mattress. A lot of times I'll just put like a little, like an air mattress, a little waffle mattress on top. Sometimes there are specialty beds that we'll use for patients who are really high risk or already have very large wounds. We want to use a lift sheet to move. How is that? For the shear, right? If we're just trying to move the patient, we grab an arm and a leg or something, we're gonna be just pulling the skin instead of lifting and moving. And we also want to make sure nutrition and hydration are so important. So the Braden scale, and we're gonna go over this, but it grades people on several things. It grades on your sensory perception, what you can feel, how often you're moist or get like incontinence or sweat, your activity level, how mobile you are, what your nutrition is, and then also your friction and shear. So we're going to go over a Braden scale together in a little bit. So I'm going to move over that. This just kind of talks again about how Medicare and Medicaid won't pay for different, for large wounds if they're admitted and we don't document that they came in with it. So again, just saying, like, it's important that we document. Yeah.
Even if they're not there for that,
Mhm.
it's still.
Somebody comes in, grandma's confused from her adult family home. She gets admitted for a UTI. She's got a stage 4 on her coccyx. They're not taking care of her very well or whatever. We don't document that she came in with that, even though she came in for UTI. Yeah. We go a few days without ever saying anything, and all of a sudden we're saying, oh, and she has this large wound to her bottom. Medicare and Medicaid are going to say, you didn't document that or say anything about it when she first came in. So it must have developed here, even though physiologically it didn't have the time to maybe develop in those 2 days that she was here. That's why it's so important. We do full skin checks on admission when anybody comes in. We want to make sure we see all those things. So signs and symptoms, you guys know if you've been sitting in one spot for a long time, it hurts, right? You might end up with an open area. Here's your color tip for wounds. Black is necrosis. What does that mean? Dead, right? It's dead tissue. Yellow is usually infected. Red means it's healing. So that's just kind of a nice little tip for the colors of your wounds. So we want to remove pressure from these people. And now sometimes people think, well, what about like a donut ring? Like if somebody has a pressure on their coccyx, have them sit on a donut. We don't actually do that. Why is that? They used to, yeah.
Go right in the middle, they're still sitting on it. Yeah.
It's more of it causes like increased pressure all around the surrounding areas. And so you could even be cutting off blood flow to those areas too. So it just, you want to just kind of have all pressure. So if somebody does have on their back a wound, usually we keep them kind of tipped on their side. If they have pressure on their heels, like an injury, what do we do for them? Yeah, prop their legs up, float, we sometimes call it floating their heels.
So if somebody breaks the cockpit, you guys do now.
If they have a open area there,
No, it's broke it.
we would still tip them on their side a little bit. We would just be really careful with moving them. We also want to make sure we debride, so any of that, like dead tissue that might be in there. And usually we won't be the ones debriding it, it'll be the wound care nurse. So I'm not gonna cover a lot about these things because we just know, hey, there's a lot of extra tissue on here. There's a lot of, looks like maybe slop. It doesn't, it's kind of yellowy. It doesn't maybe look infected. It doesn't smell infected. Wound care is gonna come and help and take care of that, maybe debride it. We also want to cleanse. 4 to 15 PSI per square inch. It just means just watch out you're not using a tiny syringe, right? Littler syringes have higher pressures. So the bigger the syringe, the less pressure. So I think about it like if I had a big, like a big syringe, like a 30 mil, like you'd use to like for NG tubes or stuff, right? You push that out, that's like a big stream of water or whatever, but it's not very hard or fast. Where if you get a 3 cc syringe and you do that guy, it's like a little arrow, like it just like pops out. It's a higher pressure. All right. So stages. Stage 1 is when your skin is intact. It's a little bit red and it doesn't blanch. What does blanching mean? Right, it's like checking cap refill, right? You can check cap refill anywhere. We always do it on our fingernails because that's easy. But turn your finger over. Look at your finger, like one of your finger pad. If you just press on your finger and let go, you should see cap refill come back. A lot of times you're going to have patients who have nasty fungal infections on their toes. It's really hard to check cap refill on their toes. You're going to do it on the tissue around on their toes. That's going to give you the same information. Stage 2 is when you start to have a partial skin loss. So the skin has started breaking down. It's not a full thickness loss, which is going to be our stage 3. It's just where this, like the top layer of skin starts coming down. Stage 3 is where you have full skin thickness loss. You might see some eschar in here. And then stage 4 is where you've fully broken through all of the skin. You probably are going to see muscle, maybe tendon or bone, and you might even have damage to those areas if the pressures continue there. Warning, I think there's pictures coming up. So we also have unstageable. And so that eschar, if it's covering the whole wound, we can't see what's underneath that, right? We don't know what it is. So that's called unstageable. Until we have a wound nurse or they get that debrided and take that off, we can't say what the stage is. So it's unstageable. And then there's also deep tissue injury. That's where patients, the skin hasn't actually opened up at all, but you might have these large bruised areas around where the deep muscle and tissue has been injured, but the skin actually has stayed intact. I'll show you some pictures here. So here, this is stage 1. You can kind of see this is, I don't know if it's the same patient, but it almost looks like a progression. So here, stage 1, it's red. It's, if I were to push down on this, it's not blanchable. You can see they probably put some like cream or something on here. That's what that white is. And then we go here to this picture where we've got where the skin has started to break down, right? See, we're started to lose that top layer of tissue. And then in stage 3, we have had that full thickness of that tissue. You can see these margins really well defined here where this tissue is lost. And then these pictures kind of show you a little bit with the layers of the skin too. And then here, stage 4, this is where you have full loss. You can see this is probably muscle down in here that might be some tendons. Sometimes you can see bone. It's pretty gnarly. Over here, you've got unstageable because it's all, that's that eschar tissue. We don't know what's underneath there, so we can't stage it. And then deep tissue, we can see like it's this dark purple, then all this pink around here. We know there's injury here, but the skin actually is still intact. So we would call this a deep tissue injury because the skin's still intact, but the tissue underneath clearly has been injured. All right, so debridement would be essential when which one of these is present? This is probably what you want with your breakfast this morning, right? You can always tell who are the nurses who really love wounds and who really don't like wounds. Because the ones of you guys who are like into wounds, you're like, yeah, give it to me. And some of you guys are like, I wish I never saw those pictures. All right, which one? And it's the eschar. I think I'm saying that right. I'm not 100% sure, sorry. But if it's that black tissue covering, that is when we need to debride it. We need to get some of that off so we can see what's going on with it. Negative pressure. Have you guys looked at these in lab? Like a wound vac? A little bit. So essentially, this shows you a little bit of like, maybe this is a deep wound this person has, and they fill it with this foam padding and attach a vacuum to it, and it sucks out all the exudate or what's coming out of the wounds. Now, wounds that are really dry, we wouldn't use a wound vac. This is usually like infected wounds that are like putting out a lot of drainage. We want to keep it dry. I believe I have a video to show you. Okay. I just thought this was cool because I think wound vacs are interesting. I'm not going to show you the whole thing I'm going to go through, but you can see this, they're putting it on actually in surgery. A lot of times they're placed in surgery, or a wound nurse will place them at the bedside or change them. So this person, I think it's actually a dummy or a mannequin, that has like a wound on their bottom. So they've already put, let's see, I need to go to 2.
Well, here's like, oh, unexplored. Hello.
And she's measuring it all. Why aren't you playing? So there'd be a bit of like a sponge into the top. Cut this foam. They cut down to the right spot. They cover this. Really want it to be airborne, like where there's no leaks around the edges. It pulls fluid out. Yeah. So once they have this a little pull for the little tube. I want you guys to know the pad is kind of bumped up a little bit. It'll go. You'll see when it activates it, it'll suck down. See how it's not a lot of suction. It's not a lot of suction, right? Like it's not like this, but it provides enough suction that it does compress those pads down. And then from the wound bed, any extra drainage, especially those wounds that are infected and are putting out a lot of exudate, it just helps to pull them away from the wound so they're not sitting there on the wound bed. So anyway, I thought it was really interesting. Maybe you're going to be a wound care nurse, you're going to be putting these on all the time, maybe not, that's okay. But it's kind of nice to have at least seen them, at least in a video before you go out, because you're probably going to see them in your clinical practice. Like in clinicals here at school, you'll probably see them eventually. Okay, moving on. All right, so we talk about nursing diagnoses as well. You guys have started working on care plans and foundations. So a lot of times talk about impaired skin integrity, risk for infection, maybe acute pain. So moving on now, so we talked about pressure injuries and with skin. Now we're gonna talk about disorders of the skin. So dermatitis, again, this is one I wanted us to use our word building, like derm, like your, like subdermal, you know, it's like your skin, right? And what is itis? Inflammation. It's some sort of inflammation of the skin. It can be, oh my gosh, it says it right there. Good readers. It can be from allergens, irritants. Sometimes you can have hereditary involvement. Sometimes it can be stress that causes inflammation. Sometimes people will be like, I'm broken out in hives and it's just because I'm stressed. Like you just never know. Our bodies are weird. We can have contact or seborrheic. Contact is usually you come in contact with some irritant. Maybe you're allergic to this specific laundry soap and you put on your clothes and you're like, oh, I'm so itchy from the clothes I just put on. You know, your skin is irritated. Seborrheic would be more of you're expressing a lot of sebaceous secretions, and that's more of a chronic condition. Here's a couple pictures. They're not great. You can kind of see where the skin is really bumpy and lumpy here. It's got a lot of irritation and raised. Here, we're really swollen and irritated. So signs and symptoms, it can look really different. Sometimes there can be scales or crusts or papules. With all of these things with their skin, we want to make sure if they're open or if a bacteria gets introduced, they can actually become infected. So we want to make sure we're monitoring for that. Therapeutic interventions, antihistamines. Have you guys talked about antihistamines in pharmacology? Mm-hmm. Yeah, right. So that's going to help decrease some of that inflammatory response. If we go back to the example of the laundry soap that was really irritating, you know, that antihistamine is going to go and try to counteract all of that production of our immune system saying this is not okay, something is wrong, you know, even though it's just soap. We might give them an analgesic if it's significant enough pain. Antipyretic, what does that mean? Yep. Steroids, right? That's also going to help with the inflammation. Sometimes we say oatmeal baths or soothing warm baths. That can really soothe the skin. And then wet dressings, especially if you're so itchy or if it just feels fiery, having a moist dressing on there can help cool and help with that pain. So itching with dermatitis. What are some things that we can do? I know I just gave you the answers, but go ahead and select all that apply. I can only choose one. Shoot. Menti's just playing with me. Sometimes they let me and sometimes they don't. All right, so we have okay. So tepid vinegar baths. What kind of baths do we want to give? It's usually an oatmeal type bath, right? We do want to pat dry with a clean cloth. So you want to make sure your cloth is clean so you don't have an infection, and you don't want to scrub at the skin, even though sometimes it's really itchy. That scrubbing can actually abrade or open up the skin. So you want to have like patting dry. Antihistamines for sure. I'm not sure if humidification was an actual answer, and I'm not going to test you on humidification, so I'll get back to that one. I'll let you guys know. And then antibiotics, no, that wouldn't be something we would treat everybody with, right? If they're not infected, we don't need antibiotics. Unless it develops. Yeah. All right. So psoriasis. So psoriasis is this inflammatory disorder that people have. It's a coloration, and probably saying it's an overgrowth of your epithelial cells, so the top of your skin. It often causes this kind of scaling look. A lot of these patients have a lot of body image issues because it happens a lot. It happens all over, and it can look really like it's noticeable. So things that can aggravate it, like we said, stress, hormone changes, cold weather. Sometimes certain medications can have an effect on it. Here's some pictures of it. So you might have seen people that have this and they can have it on their face. They're like all over their body. It can be. And a lot of times people think it looks like an infection of some sort. And it's really just this overgrowth of skin that happens. It's usually very itchy as well, really uncomfortable. I know when I was growing up, there was a young man who had this and he would only shower once a week and everybody was like, gross, you shower once a week. But now I'm realizing he keep his skin more moisturized. He wasn't trying to wash away all of the moisture and his on his skin. And I don't know if he had the right type of body products, right? The average soap might be irritating to them. So with this, we want to make sure we're looking at a physical assessment. We want to make sure we're ruling out an infection, right? Like if you know, sometimes it looks similar to some infections. We want to make sure it's not an actual infection, like we'll talk more about it. Sometimes they'll do skin biopsies just to make sure. So again, they might have some of those baths, adding in some of that nice oatmeal to them. They might have all these medications. Sometimes the vitamin D creams or the retinols can be helpful. I've seen patients with UV light. They go and have like tanning, and that actually can help with the psoriasis, right? Like it's usually not something we recommend, but a dermatologist sometimes they do recommend that. When it's very bad for patients, sometimes they are on some chemotherapeutic drugs just to stop that overgrowth of tissue. Fish oil supplements can also be really helpful for patients too. So there's a lot of variety. It just depends on what works for that patient with how severe, you know, their process is. All right, let's move to herpes. Okay, so herpes is a viral infection. When we talk about herpes simplex, there's two. There's a 1 and a 2. Herpes simplex 1, above the waist. Herpes simplex 2, below the waist, right? So above the waist, you can have herpes simplex on your fingers. A lot of times people think about herpes like around their mouth or their lips. They can have that. Below the waist, it's usually a sexually transmitted disease, right? So direct contact, yeah.
Does everyone have HSV1?
I mean, probably, right? Because of life and we've touched everything and most people have herpes simplex 1. I wouldn't say everybody because some people might just have great natural immunity from it, or they've never been kissed. So it's always spread from either direct contact. If it's like herpes simplex 1 above the waist, maybe there's some like droplets of coughing, or sneezing, some sort of fluid exposure. When you've contracted this, it lays dormant in your system, waiting for the time to come alive and show what it is. Usually recurs with stress. So stress means you get sick, you're going to get married, you're going to like whatever it is that's causing stress in your life can cause this to flare up. So there's different stages. So you have this prodromal phase where there's just burning, and this is both for simplex 1 and 2. Then you have vesicles and pustules, which is what we saw earlier, right? Then they eventually they'll burst or open and a scab will form. Patients are contagious until that scab forms up and kind of closes in. So it's important that patients know if they have herpes simplex 1 or 2 to know when they're in one of either the prodromal or the vesicular phase that they are contagious and they need to take precautions. Don't kiss somebody. Don't sleep with somebody. Therapeutic interventions. So sometimes, you know, if it's really causing issues, it could be very painful. It could hurt, that burning. They might be on an antiviral agent to help control that. Sometimes it can cause a secondary infection. If those pustules open up, that's an open area and bacteria could get in there and cause a bacterial infection as well. That's called a secondary infection, where your primary infection was that virus, but then the bacteria is like, hey, I'll take that, you know? And so that's called a secondary infection. So we would give antibiotics for that. And then we try to teach patients, like, what causes your triggers? Is it stress? You know, maybe we can't reduce stress. Maybe you're in nursing school and you are stressed forever. It's not forever, it does end. You know, but teaching about how do we manage our stress or whatever the triggers are. Then there's herpes zoster, also known as shingles. Yeah, so they actually look very similar to this. They're really painful vesicles, and they follow a nerve distribution where, like we talked about herpes simplex, it can be, you know, above the waist, wherever, below the waist. Herpes zoster actually follows nerve patterns. So a lot of times you'll see, sometimes they call it dermatomes. It's usually on one side of the body or the other, and it will follow that nerve pattern. A lot of times on the chest, we'll see it kind of follow this, like a nerve across one way or the other. And it's, like I said, usually just on one side. It's usually the reactivation of varicella zoster virus, which is Chickenpox. Just out of curiosity, has anybody actually had chickenpox? Not the vaccine, but actually had chickenpox? Okay, I'm always curious because as we have, I mean, when I was a kid, they didn't have chickenpox virus, so I just had chickenpox. We would have pox parties. The moms would all get together and be like, "Oh, your baby has chickenpox here. Let's all get them together and play." And then they can all get sick and they can all develop immunity. And I mean, it actually wasn't a bad idea, you know. But with herpes zoster, you have to either been exposed to chickenpox or had it or had the virus. Something in your system already has like been exposed to the chickenpox virus, and it's a reactivation of it. It's only, not everybody will get this, but it's usually people who are immunocompromised, the elderly, people who are immunosuppressed, maybe who have AIDS, you're a lot more compromise or potential for it. Yeah.
It is crazy because I feel like it is starting to develop in younger people now. 'Cause I have been having some patients, like
Really?
we had like a 30-year-old that had it.
Yeah.
And then we did, I'm pretty sure he was 12.
Mm.
Very rare in a kid.
Yeah.
and the doctor was like, I'm pretty sure that's shingles, and it was like
Interesting.
very interesting. And I feel like, I don't know.
Yeah.
If that's a thing or it's just rare.
I'm not
Or-
sure. I know that we looked at patients, and if they're at high risk for getting shingles, if they're immunocompromised, things like that, we do recommend a vaccine that can help prevent shingles. Now, again, it's not for everybody, unless you have a significant risk factor. It's really painful. My mom, she had a liver transplant when I was little, and I remember she got shingles about a couple months after her transplant. She's very immunosuppressed because we don't want her body to reject her liver. And she was just like, "Oh, it just hurts." And we went to McDonald's and we're standing in line. I'm like, "Mom, is your shingles hurting you?"
Oh.
Because she was like doing like this type of thing. And she was like, "Shh." Did I say shingles? I think I said herpes.
Oh.
I think I said something wrong. I said something wrong where she was just like, "Who said that?" Anyway, so there's a difference between herpes and shingles. My 12-year-old self did not know. All right, moving on. So we already talked about what it looks like. Just so you know, it follows those nerve patterns and it does cause a lot of nerve type pain, burning, tingling, and it can last for a long time, even after that skin has healed over. Sometimes they have, like for years, they might have some of that pain associated with where they had shingles. Again, they might have some antivirals, analgesics, anticonvulsants, or antidepressants. What might that be? Like, what kind of medicine are you thinking you might get? We've had it in our med sheets for the past 2 weeks. So.
Start with a T
Usually with an N or a G. Like Neurontin or gabapentin.
Oh.
Yeah, right, because they're traditionally were used for anticonvulsants, for seizures. We also know they can work for nerve pain. So specifically for patients with shingles that have this nerve pain, Neurontin or gabapentin is one that can really help with this nerve pain. All right, moving on.
Question of
Yeah.
shingles. If you didn't have chickenpox, you weren't exposed at all, and someone with shingles came in contact with you, would you then get chickenpox?
That's a really good question. I'm not sure. The question was, if you've never been exposed to chickenpox virus or anything, or vaccine or anything, can you get shingles? I don't think so, because it's a reactivation of it. Could you get chickenpox? I don't know.
Yeah, like if you were
Yeah.
exposed to that shingles. Like, would you
Yeah.
get chickenpox?
Yeah, I'm not sure. That's a good question. Interesting. If we find out. All right, so really quick, you're caring for Mr. Wingate, who's hospitalized for complications of diabetes. As you help him bathe, he states the skin on the left side of his back is really painful. You know, a pattern, of red vesicles in the area he indicated. What should you do? So turn to your partner or somebody beside you, and just really quick, what are some priorities that you would do?
That's you.
All right, let's come back together real quick. So we want to avoid touching the area, right? First of all, we know it's painful. Second of all, hopefully we have gloves on too. Oh, if you've not had chickenpox, you could contract the virus. Hey, our question got answered. Okay. It could also be spread to other patients. So we're gonna put him on contact precautions because we don't want to spread that to other patients around. We're gonna talk to the RN or the healthcare provider to get an official diagnosis. And then we're gonna look about pain management, right? Because he's probably really uncomfortable, really hurting. And then again, isolation. And generally, if you're ever concerned somebody has a communicable disease or a communicable infection, anything, put them in isolation, put them in contact precautions, right? Because that's a precaution. It doesn't mean you're diagnosing. It's a nursing intervention to say, hey, until we know differently, I'm just going to put them in precautions. And then maybe you'll find out, they don't need to be. I think it's better to protect the other patients around you by kind of contact, like protecting them against that patient, than waiting for a provider order. All right, so now let's talk about fungal infections. So it's usually a direct contact with fungus or an overgrowth. Sometimes antibiotic therapy. And when we say overgrowth, what we mean is we have this normal flora that lives on us, which we have this like lovely system that protects us on our skin. Like if you could like zoom in a million times on our skin, we've got all this wonderful good bacteria and good fungi and things that live in harmony to protect us from outside invaders. However, there can be imbalances, right? They're balanced, they're coordinated, they're playing happily. There are some times, so think about somebody with antibiotics who that antibiotic is killing bacteria, regardless if it's a good or bad bacteria. So on our skin, all of a sudden, this bacteria is killed off. And so the fungi are like, hey, I've got the town. So a lot of times what we can see, let's say you're a woman or men, either one, and you have an infection, you have strep throat, you're on antibiotics. Maybe suddenly you develop a yeast infection, right? Same thing for men. It's an overgrowth. And we say yeast infection, that's just an overgrowth of yeast or fungi in your perineal area. Men and women can both have it. Women, because of anatomy, are just a little bit more equipped to have it, or they're just more by design. Women have yeast infections in their groin more often than men. So it's an overgrowth, it's an imbalance. Sometimes people can just have this without having antibiotics or something else. So you want to try to help them to balance out things. You need a warm, moist environment. So if you think about your patients, the groin is an obvious choice for a warm, moist environment. What are some other areas you want to look for yeast overgrowth? Rolls, armpits, right? In the mouth. Yes, the mouth is a good one. A lot of times we see that in babies. In fact, nursing mamas, when they're saying, my nipples are killing me, they hurt so bad, one of the first things that you should look at is to see if their baby has a yeast infection. That yeast thrush, yep, is also called thrush. Because if the baby has a yeast infection, they're transferring that to the mom, which can cause a lot of pain on the nipples. Pain in breastfeeding. It's easily treatable, but it's something that we don't always think about. So here's some different types of fungal infections. Tinea pedis, or athlete's foot, Papidus on the scalp, or Corporis, which is just kind of on the skin. And you can see how sometimes these almost look like psoriasis, right? And that's why sometimes we want to actually get a skin biopsy or check that it's not psoriasis, isn't an infection. Here is like like jock ringworm on a man, clearly. But then here's thrush in the mouth, those little white papules. Those are like textbook perfect. I mean, perfectly wrong, right? We don't want to see those, but when you have somebody with thrush, that's what you're gonna see. All right, so moving on, cellulitis. We know that itis is there, right? That's inflammation. What is cellu or cellia? In your cell, it's just kind of in your tissue in general. cellulitis can happen almost anywhere. It's just whenever you have an inflammation, usually infection of your skin or your connective tissue. Oftentimes we see it with a staph or strep infection. In fact, sometimes we see it with Staphylococcus methicillin resistant Staphylococcus aureus. What does that stand for? Or what's the shorter? MRSA or MRSA. So sometimes, like, how do you get it? Like right now, my mom, immunocompromised transplant person, has cellulitis on her leg. She has no idea how she got it. She sent me pictures the other day. Her skin was kind of red. It was a little swollen, warm. I was like, I don't know, Mom, you should go get that checked out. Well, she has cellulitis and now she's on antibiotics to help with that. Sometimes we don't know. Sometimes there can be trauma from the outside that causes damage. Sometimes on the outside, there's a cut or there's some sort of opportune, like open area. Sometimes we just don't know what happens, but you're gonna see warmth, redness, swelling. It's probably gonna be painful, tender. They might even have a fever and they might have lymphadenopathy. I'm not saying that right, but what does that mean? Your lymph nodes are swollen. Yeah, when my kids were little, when they would get sick, I would notice my son, especially, he would have like his lymph nodes on the back of his head would get about this big. The first couple times it happened, I was like, he has cancer, he's gonna die. Like, and it was just his lymph nodes were getting swollen as a reaction of his immune system. So with cellulitis, we want to make sure it's localized. It's just in that one area. So with my mom, I don't know if they did blood cultures, but if she had been getting worse, they definitely would check blood cultures to make sure that infection hadn't spread to her blood and gone system-wide. What we do for it is we give antibiotics. Sometimes if the cellulitis is small enough, right? Because you can have cellulitis on your finger, or it's like it can be anywhere. It can be big or small. If it's smaller, you can do topical antibiotics. You don't need to get them all through your system because it's small enough. If the cellulitis and infection is big enough, you might need systemic antibiotics, which is like a pill that you would take that goes through your whole system. Now, those have some negative side effects, right? Like we talked about how they can cause the imbalance of bacteria and fungal growth. And so we just want to make sure we're giving them judiciously. Sometimes they might need to debride the area if it's really infected and they need to get some of that infected tissue out. They might have to do, sometimes it's called an incision and debridement. So incision, they open up the infected area, clean it all out. That can be done at the bedside. Sometimes you'll see it in the ER. Sometimes they can do it in the OR. Yeah.
What's the difference between cellulitis and gout? Because I feel like I get patients that come in and it's like, it's either cellulitis or gout, because it's kind of the same thing.
Yeah, so with gout, like we learned before, it's the uric acid that builds up and it causes inflammation in the joint. And so because of that inflammation in the joint, it gets swollen, it's painful and red, but it's not necessarily infected. If it gets infected though, that could be cellulitis from the gout. Yeah, so it could be both together. Oh, and elevate, right? Lift your finger, keep your finger up. Lift your leg, keep your leg up. Lift your bottom, you're out of luck. Unless you're like, want to do yoga. We do want to make sure we monitor for sepsis, and then we want to measure the area to monitor progress. When I think I told you guys, I worked like as a camp nurse with my church. So when sometimes kids like come in and I'm like, ooh, that kind of looks infected, I just grab a Sharpie and I draw around it, right? And then I could come back later at dinner and say, let me see your arm. And then hopefully that line now has like the red inside the line, it's shrinking. But if like the redness is growing outside the line, that lets me know that that infection is getting worse. You want to do that with your patients in the hospital. If you feel like you got this raised area or swollen area, it helps you to measure it. Pediculosis. Anybody know what that is without looking? It's lice. Okay, people get lice. It's a fact of life. So it's transmitted by direct contact with either the person who has lice or with their belongings that the lice pitched right on. So pediculosis capitis is like a cap that's on your head. Pediculosis corporis on your body, and then pediculosis pubis, pubic lice, right? If somebody has pubic lice, we're also going to be testing for STDs usually as well. That's just part of protocol. So you're going to have itching, rash, and then you usually will have, you can either see lice, which are teeny tiny little guys, or nits, they're little eggs, and then excreta, which I'm not sure what the poop looks like. I've only seen the lice or the nits. So how do we know if that's what it is? Well, you ask the person and then you look. And then, like I said, we also test for STIs if it's pediculosis pubis. Did I say that right?
It just seems like something we get like.
Pediculosis?
Yeah.
Yeah. I think of, the way I help me remember is the losis, like lice, los.
Okay.
That's kind of helps me to remember. So you want to make sure that we treat it. So we were going to treat by, there's some medications you can use. You also want to make sure that you mechanically remove them. There's a lot of like lice brushes and picks and all kinds of things to try to remove not only the lice themselves, but the eggs, right? Because if we haven't treated well enough and the eggs are still there, they can hatch and then have a little happy home wherever they're living. Antipyretics, sometimes it's very itchy, so they might need some itching medicine. And they might need some topical steroids also to help with that inflammation. We do want to talk about patient education, especially about treating the area around them. Usually we want patients to treat their bedding, to treat their, if little kids, they have stuffed animals, right? We want to treat them. And a lot of times too, talk about family and friends. Unfortunately, people see lice as a dirty disease. Oftentimes lice like clean hair. They like clean people because they can get to your scalp. If your scalp is really oily and dirty, the lice can't get there and live as well. And so they don't like people with dirty scalps as much. So I try to tell people that like lice isn't a dirty thing. It's just part of life that happens. And if you do get it, please tell all your friends so that they can check their kids or whoever too, because otherwise you can have it just like moving through the community because nobody wants to talk about it. Scabies, even more fun. Even seasoned nurses get scared of scabies. They give me the icks.
Yes.
They are little mites and they burrow underneath your skin. It is icky. Usually you can get it from contact with the patient who has it or with their environment that they've been around. You can kind of see it's like red and it's kind of these little raised areas. It's raised and inflamed because they have little mites living underneath their skin. I know, we're all like so itchy right now. So the patients are going to have this kind of rashy area itching in these little burrows of where the little mites are living. Super fun, right? So how do we know that it's scabies? Well, usually they'll do like a little shave, which just means like they'll take the skin and kind of, and they'll send that to the lab and the lab will say, yep, you got a winner. And a lot, yeah, and they're homeless patients, right? They're at huge risk of scabies or lice, or a lot of these things because they're not able to, hey, stay away from other people who might have it or to treat their belongings or themselves as well as they should. So they're at big risk of having scabies or lice. Yeah. So again, warm soapy baths, just like a lot of our patients with skin issues. The soapy, different than the oatmeal baths. Oatmeal baths will probably help as well with these people. Want to make sure that they know that their itching might continue for 2 weeks, even after they're treated, because that skin is just going to continue to be inflamed for a little bit until it heals. So sometimes patients are like, I'm not like you treated me, but I'm just still miserable. They're going to be probably miserable for up to 2 weeks. And so it's important that we tell them that so that they know, so that they can continue taking the baths, continue taking the medicine to help feel better. For even more fun, let's talk about cancer. So you can have skin cancer, and the thing why we're talking about skin cancer now is because it can look very similar to some of these things we've just been talking about. And so I want to make sure that we're aware of what those might be. So here, basal cell carcinoma, see, it has this irregular shape to it. That's one thing you really want to look for. If something is raised in your skin and it has this, it's not only irregular in the shape, but see how right here, it's not really raised up. It's kind of flat there. That's irregular in a lot of places. So that makes me a little bit concerned. So we would want to definitely make sure they go get that checked out. There's also squamous cell carcinoma. And here you don't have a lot of raised areas, but you have discoloration, you have a very irregular border, and then you have a real funky area of it too. That all looks a little bit concerning too for me. Here would be a malignant melanoma. I think this is between a toe is what we're looking at. This could almost look like a skin, like a pressure wound, an eschar, right? But it's actually cancer. That's why it's important we're looking and we're, pulling in our providers to help us like say, hey, I don't know what this is. Let's take a look at it. Okay, so when we're talking about malignant skin lesions, what's really important for the nurse to teach patients? Yeah, we want to avoid overexposure to UV rays, right? Showering is not going to give you cancer. Allergens or irritants prove we won't, and then you can't contact a malignant lesion unless you could contact scabies or lice or something like that. Some risk factors for skin cancer. A lot of exposure to UV rays, overexposure. If you are fair-skinned, you are more likely to develop a skin lesion. Genetic tendencies, just like some people, hypertension runs in their family. Well, you might have a risk factor that's higher for skin lesions as well. If you have a lot of X-ray therapy, certain chemicals, you're exposed to those, that can make you a higher risk of having skin cancer. And if you have immunosuppressive therapy, anytime your immune system is being suppressed, it can't fight off things, including cancerous cells. So prevention, especially if you're fair-skinned, we say use sunscreen when you're out. Wear protective clothing. If you have moles or skin, you've always had this like red area on your skin. If that starts changing, you want to let your doctor know because that's abnormal. And then, the doctor's just going to look at it. They might do a little bit of a biopsy or they might remove it. There might be chemotherapy and radiation depending on the extent of it as well. Done. Okay, you guys ready for a bathroom break? So ready. Okay. Let's come back at 10 after. So short bathroom break. Okay, well, if you're watching from home, you missed out on a scintillating Braden scale discussion. So go ahead and join us in this new Menti. Let's see, would somebody write the code down for me in case we get locked out?
2478, 2478, 4448, 4448.
Sound good? Okay, once you're in this brand new Menti, please give me a thumbs up, no cats or question marks or thumbs down for this one either, sorry. All right, so we talked about skin, and we started to talk a little bit about infection. We're going to talk a little bit more. First question, right off the bat, what action can the nurse take to break the chain of infection as far as the mode of transmission? Let me move this a little bit. And you guys are, wait, you are correct, right? You're correct. Move here. Yes, practice hand hygiene. Yes, the transmission link, right? We're using hand hygiene. We're not going to carry those germs from one person over to the next. Not that you're infected with yours. I gotta click back in here. All right, so this chapter talks a lot about the chain of transmission, but you guys have already talked about that in fundamentals. So I'm not going to bore you with talking about how you have to have like a reservoir and all these other things of how it goes, because you guys already covered that. What I'm going to talk about more is the susceptible host piece, right? Because you have to be, in order to get an infection, you have to be a susceptible host. So that may be somebody who has burns, which we're going to talk about, that opened areas of their skin. They might have chronic disease or they're immunocompromised. If they have an invasive procedure like surgery that opens up, they're more of a susceptible host. Sometimes if you're malnourished, you don't have all the nutrition you need, you're stressed, or if you're on the very old end of the scale or the very young end of the scale, you're at more risk of getting an infection. So the immune system is the body's final defense against infection, right? we have a lot of, like we talked about, this nice barrier of our skin and all the flora that live on it to help protect us. But if something comes in and gets into, it's an intruder into our system, our immune system is not only the alert system, but it's also the like attack system that it wants to attack those invaders. Infection results when that protective system fails, right? It might still be working, but it doesn't totally, it's not able to stop that infection from happening. So when you're collecting patient data, which disease would the nurse recognize as signs and symptoms of a localized infection? So think about localized. What does that mean? Oh, good. It let you choose more than one. Yeah, nice job, you guys. So redness, swelling, and warmth. We talked about cellulitis when we were talking about skin earlier. And so that's an infection of the skin. We're localized, right? In a local spot. We're gonna see it. The specific area, like my mom has cellulitis of her leg. It was red. It was swollen. It was warm to the touch. When we say warm to the touch, what we mean is feel something away from where it's infected, and then feel that area that we're suspicious of it being infected. That area that we're thinking is infected is probably going to be more warm than the other skin around. A localized infection, it's just that one area. Like I said, it's not through the rest of the body. But sometimes we can have what's called sepsis. Sepsis is when that infection has spread to the rest of the body. And that affects us in a bigger scale, where a localized infection, just one area, just the sepsis or the cellulitis in my mom's leg. But if it spreads to the rest of her body, now that infection is trying to get into all the organs, all of the body systems. It can be life-threatening. So we really want to look for, anytime somebody has an infection, we want to be monitoring for sepsis. It can lead to septic shock, which is this drastic decrease in blood pressure. So if you ever have somebody who has a localized infection, they're not looking good, and all of a sudden their blood pressure really starts dropping, I want you guys to think about septic shock. You guys are going to learn about shock in MedSurg 3, so it's not for a while, but that's just a little bit of a, like, put a tack in that. When you go have MedSurg 3, you'll think about it. So when we have somebody we're worried about having sepsis, we're going to look at a couple of things. Laboratory, we're going to get a blood draw and look at Gram stain. You guys remember Gram staining from was it micro, or did you do it in A&P or in micro? Okay. Yeah, so that's going to help us know, is it gram positive or gram negative bacteria? We also are going to do culture and sensitivity. What does that tell us?
Oh, for the antibiotics?
Yeah, what antibiotics are going to kill it, right? Usually you'll start somebody on a broad spectrum antibiotic. And then once you get your culture and sensitivity back, you might change that. So it's a little bit more specific for what that patient's on. When do we want to get our cultures? Right away. Do we give those before or after the antibiotics? Before, because we want to know what that infection is without anything else in their system. If we give them antibiotics right away, that antibiotic could start working a little bit. It's a good one. And then our culture and sensitivity is not going to be as accurate. So always get culture and sensitivity, blood cultures, then antibiotics. We also are going to check a CBC with differential, which just means all of the white blood cells. We want to know all of those different levels, the different types of white blood cells. And we want to get an ESR. That's going to tell us about inflammation in the body system. Immunity. So when we talk about immunity, we're trying to help that susceptible host be immune to something or have a greater defense against getting it. So we talk about natural immunity, like kind of a species specific, meaning that there's certain diseases or infections that might affect animals that don't affect humans. And some that affect humans but won't be transmitted to animals, right? Remember in the beginning of COVID, we didn't know if dogs could get COVID or not. So we're like, oh, don't let your dogs play together because we don't know what's going to happen with that. But then we found dogs can't get COVID, so that's okay. Innate immunity is hereditary, right? Some people are just less likely to get certain diseases. They just have a better immune system that's more triggered to be immune to certain things. Then there's acquired immunity. That's what a lot of times we as nurses talk about, because disease exposure and infection. We talked about chickenpox earlier, right? If you had chickenpox, you were exposed, your immune system created some immunity against chickenpox after that, so you won't get it again. Vaccines do a very similar thing, right? They either give you a dead part of the virus or they give you something that helps trigger your immune system to say, hey, now I can recognize this. So if I'm exposed to it, I won't actually become infected because I have the key to know how to protect against it. I'm not going to get into the immunoglobulin injection. So herd immunity. I know, and when COVID was first happening, there was a lot of discussion about herd immunity. That's like when I talked about the chickenpox parties, right? That my family would have. It's because you want to, if you can get enough people that have immunity against it, it's not going to go and spread through. And the reason why moms did this, which is actually very smart, if you have kids that are younger that have chickenpox, they tend to handle it really well. If you have adolescents, adults, even older adults who get chickenpox, they actually get pretty sick from it. It can be a lot more debilitating to those older adults. And so those mamas knew that. And that's why they would say, hey, somebody has chickenpox. I'd rather have my little 2-year-old get chickenpox now and be a little sick than for them to be years later and never get it and get really sick, right? So that's part of the principle of herd immunity. Part of the whole thing, and also it could be from vaccination as well. If we can vaccinate enough people as a greater, like we say herd, which sounds like cattle, but it just means like if you get enough people either vaccinated or have resistance to a certain disease process, then you're not going to be acquiring it and transmitting it to everybody, and it really helps protect the whole population. So a nurse would be correct in explaining to a patient that innate immunity is obtained in which the following ways. Talking about innate immunity. Is that genetic, globulin, organism, or vaccination? Excuse me. And genetics is correct. Yes. Innate means that I have it in me. I'm just naturally have this defense. It's not when you've been exposed. Excuse me, because that occurs from the exposure.
Excuse me,
Yes.
what kind of immunity is the innate immunities? Can you give examples?
It just depends. Some people never seem to get the flu, like influenza. They just have this innate with their system that they just don't contract it. Other people, like GI diseases or GI, like some people, like they will get diarrhea no matter what. Other people, they're like, I have an iron stomach. Whatever happens around, it never bothers me. They have this innate immunity in their body that their body fights an infection or a potential infection really well. And it's different for each people. You might have an iron stomach while somebody else never gets the flu. Somebody else, has other innate immunity. Does that help at all? A little bit. All right. Some disease examples. We're just going to brush over these. We know we've talked a lot about COVID-19. There's Ebola, right? Fortunately, now we do have a vaccine against that. We don't really see Ebola here in the States, but it's still in other countries. You might see Ebola. Infectious mononucleosis. Maybe you've heard it called mono, like the kissing disease. It's from the Epstein-Barr virus. I got this when I was in my late 20s. I felt really sick, like I was out. Usually it's teenagers who get it, and it can be very debilitating. Like usually they're like, whoever gets it, they're out on the couch for a week or two, and they're just so tired. It's you feel a lot of fatigue. But there's not a lot we can do. Once you have this, it's more of what we call supportive care, meaning how do we support the body to fight this disease? So it's all of those natural remedies. Let's do some chicken soup. Let's rest, let's maybe get some sunlight on you. Let's get some fresh air. All these things that we know can help people get well. Community infection control, just so we know, like, we talk about infection or things like in our neighborhood, like our local health department, but really that not as controlled, but that's kind of regulated by the Center for Disease Control and Prevention, right? The CDC. We also have World Health Organization. So for the whole world, we want to share information, right? Because if we have, maybe in the US, there's some things, some studies, and we're like, hey, there's evidence-based practices that say, don't have a diaper on an adult person because it could cause skin breakdown. We want to share that information with people in other countries. And so usually we take it to the World Health Organization and they look at things, or maybe they share with us and say, hey, you Americans have been inflating the balloons for Foley's. Stop that. It's not good anymore. You know, we want to share information. So just know when we talk about immunity and like infection control, we do want to share that information because people travel, right? As people move from one country to another for leisure, for work, for whatever it is, they can also travel with those diseases. And so we want to work together with other countries. When you're in a healthcare center, nursing home, hospital, doctor's office, wherever, usually nursing, somewhere somebody's staying long-term. When people get an infection, we talk about it in two ways. It's community acquired or healthcare associated. Which one is probably not good? Healthcare associated. That means we gave them the infection of some sort. Community acquired, somebody comes in with a cough, they have pneumonia. They got that out in the community and now we're taking care of them. But maybe they're lying in bed and we're not turning and repositioning them, we're not doing what they should, and maybe they get a sore and that gets infected. That's a healthcare associated infection. Or we talk a lot about Foley catheters and dwelling catheters being a big risk of having infection. If they get that infection from the Foley catheter, that's a healthcare acquired infection. So does that kind of make sense of things that we introduce, even if we need to, right? Maybe they need a Foley catheter. We've done everything we can to prevent infection. If we gave it to them, we got to own it. It's still from us.
The same as I remember studying yesterday, the nose and pinhole.
Yes,
Same.
yes, yep, just a different word for it. So risk factors, we talked a lot about this. The host's condition, the patient's condition, if they're on a lot of different antibiotics, sometimes that can decrease their ability to have those protective bacteria to help fight infections. Also, if they're in a high-risk care unit, like we think about the ICU or other areas, that puts people more at risk of having infections. Some common pathogens that we see are E. coli, Staphylococcus aureus, or Pseudomonas. So hand hygiene, so important, right? I feel like almost there's always NCLEX questions that I hear from students that the correct answer is always hand hygiene because it's so important. It's true. Like hand hygiene is something that is so simple and easy and effective. It's also really easy to not do it or not do it well. So please make sure we're using good hand hygiene. Asepsis. You guys have talked some about this with wound care, where you have asepsis and then sterility, right? Asepsis, we're just keeping everything as clean as possible. Where sterility, we're keeping things sterile. We're not touching anything, you know, that's not sterile. Some places use UV lights to cleanse. Many places use, what's it called, like the Trudy machine or something like that anymore. For certain infections, C. diff or other things, there's UV light can be effective at killing bacteria. So they would go and put these machines in the room. They would light up and it would smell like a tanning bed and it would clean all those infected, like whatever was in the room. You can also have infections that are resistant to antibiotics, right? Which is why we talk about patients we only want to use antibiotics when it's indicated, right? If it's a viral infection, you don't need antibiotics because they only work against bacteria. Or what about patients who don't take their medicine as long as they should? They might get it again and develop a super infection, which is a antibiotic resistant infection. The way I like to think about it is back in microbiology, when I was learning about antibiotics and bacteria, is that in the first think it's what, 3 to 5 days, most of those bacteria, the bad bacteria causing infection, they kill off. But you still have some bacteria that are trucking along. That's why you need to take your antibiotics for either 7 days or 10 days, whichever it's been ordered for, because it's going to kill all of those little kind of super strong bacteria. If you stop taking it, once all the majority of the bacteria have killed off, the patient's probably going to feel better, but they still have extra little bacteria living. But now those bacteria, if you stop taking the antibiotic, they're like, hey, got your number. I know what you're going to try to throw at me next time. Over time, they become resistant to that antibiotic. So that's how we get MRSA, right? Methicillin resistant Staphylococcus aureus. Or VRE is vancomycin resistant enterococci. We haven't finished, not always, but a lot of times it's because we haven't finished the full course of antibiotics. And so some of those little bacteria live beyond, and they've learned and developed how to resist that antibiotic, which is kind of scary because vancomycin used to be the one that would kill everything, right? In fact, vancomycin is what we give for patients who have MRSA. Somebody has MRSA, vancomycin is the drug of choice for somebody with MRSA. Now, if somebody has vancomycin, got to get a new medication for them, right? So we're always trying to stay ahead of the bacteria, right? Anybody watch, what is it, Last of Us? The show with the fungi and everything. It's crazy. Anyway, we have a very interesting world. So treatment. If it's a bacterial infection, we give them antibiotics. If it's a virus, we can do antivirals if it's appropriate. Sometimes that can help. If it's a fungal infection, you want to give them antifungals. So important that we teach patients because there's a lot of over-the-counter like antibiotic creams or antifungal creams. But let's say we have a woman who has a yeast infection in her groin and she is thinking it's like a bacteria or something. She's like, oh, I think that's a bacteria. So she's putting like a bacterial antibiotic cream on there. What's that going to do? No, it's going to make it worse, right? It's going to kill off all that good bacteria even more and have it even different, like overgrowth. We do monitor peak and trough doses of medicine. Have you guys talked about this in farm? Peak and trough a little bit. So just so you know, if you have somebody, especially on IV antibiotics, we want to make sure we know at the peak level that's working, is it therapeutic? And then we want to see at the trough, like, so here it is, they get an initial dose and then it peaks up. This is as much as we want to give them because otherwise it could start hurting their kidneys, right? Then we want to make sure the trough is about as low as it gets to still remain healthy. Usually at this trough level, that's when we would give them another dose. You usually will draw blood levels at this trough level right before you give them another dose because you want to make sure at this trough level, it's still in this therapeutic range. If that trough level is too low, we probably need to increase the dose. If that trough level is pretty high, we need to back down on the dose a little bit, right? So sometimes you might be drawing peak and trough levels on patients. These are a bunch of antibiotics that we're not going to talk about. And there's also antibiotic-associated diarrhea, which means antibiotics can kill off all that good bacteria in your gut, meaning you can get diarrhea because you don't have that good bacteria to help digest and regulate. You can have inflammation and watery stool, and it can resolve when the antibiotics are stopped. It can also continue on. Also, I like to make sure patients know, right? If you send somebody home with an antibiotic prescription, please tell them you might experience diarrhea. In fact, there's some things that we can help do to prevent that diarrhea. What could we suggest? If they have diarrhea, put them on the rice diet. I also like to suggest probiotics for our patients too, like things like yogurt that have a lot of live cultures in them, or even over-the-counter probiotics. There's some different schools of thoughts as far as maybe take your antibiotic at one time a day and then take your probiotic at another time of day because they might, who knows, it's not clear as far as the effects of each other, but that the probiotics can help with the diarrhea. We also have Clostridium difficile or C. diff. Anybody know what C. diff smells like?
Horrible.
It's a
No,
very
it's very-
distinct smell. Once you smell it, you won't forget it. It's an overgrowth, with imbalance of that gut. It can be associated with antibiotic therapy, usually with patients who are immunocompromised. When I was a nursing assistant, and then when I got my license, I worked on this transplant floor where there was so many patients who were very immunocompromised from having a transplant. And they, not that they got C. diff all the time, but it was pretty common to have patients with C. diff because they were so immunocompromised, it was easier for them to contract it. They can also get pseudomembranous colitis, which is a life-threatening condition. I just want to say that this can be very debilitating. Sometimes these patients are just absolutely tied to the bathroom. They cannot drink enough fluids or eat enough to, you know, keep up with all of their, you know, needs that are getting wasted out. So because of that, we want to make sure we don't spread that, right? The really good hand hygiene. And what kind of hand hygiene? Soap and water, because C. diff is a spore. For extra credit, that's not gonna count in any test. What's another spore you might see? Probably not. Anthrax. Anthrax is also a spore. It's just a fun fact. We probably won't ever see that in a test anywhere. But when they talk about like all those signs, they talk about certain conditions that need whatever, it's like spores. And the only ones I've really heard of a lot are C. diff and anthrax. Hopefully we never have to experience that. So treatment, they might get some antibiotics. Here's the thing, vancomycin to treat C. diff. What's different about how we give it? So vancomycin, we give this for like MRSA or other infections, given IV. That's your clue. When you have somebody with C. diff, what route do they give the vancomycin? It's oral. It's a vancomycin liquid suspension, and that's given for C. diff specifically. It just acts directly in the gut. You would never give that suspension in the IV because it's a different formula. So it's always labeled very carefully. And you wouldn't want to give vancomycin IV because that's going to affect all the rest of the body as well. Right? We do have fecal microbiota transplantation. On the unit that I worked in, we did. It's a fecal enema and it is a transplant. And generally what it just means is that you are somebody who is absolutely debilitated because you have C. diff and you cannot leave a toilet. Like you're just pooping all the time. So usually a loved one would be a donor. And yes, that means they would poop and bring it to us. And they usually were a little embarrassed when they did, but it usually was in a brown bag. And then you would take that and you would mush it up with whatever the protocol was, I think like saline or water or something. And then you just run that into the patient as an enema. Sounds disgusting, right?
Yes.
Poop is our waste, but inside of that waste, there's all of the positive, good bacteria that person didn't have. And now they're able to get that. There's a really interesting documentary right now on Netflix called something about pooping in our gut. Anyway, I watched it. It was very interesting. And there's a gal who actually makes her own like poop pills. Because some people do take them as pills and swallow them. Like you put it inside of something so then a capsule, thank you. Anyway, this is so effective. I would see people who were gravely ill, months in the hospital, and then after getting one of these fecal transplant enemas, doing well, being able to leave the hospital. It's really amazing. So seems gross, but I'll post a link to that Netflix documentary because it was super, super interesting. Oh, sometimes it's not always with enema. Sometimes they do it with like a nasal gastric tube. I don't like that. I mean, it gets farther in your system, but I would have trouble with that if I was a patient. Okay, which of these preventative measures does the nurse implement to prevent C. diff transmission? Select all that apply. Yeah, so we want to wash with soap and water, contact precautions. Mask wearing isn't actually indicated. I mean, if you are dumping fluid into the toilet, you want to wear your full precautions, but not just a standard mask. You'd probably want like a mask with a face shield if you were like dumping. And then lidless toilets, that just means like, we want to put the lid down when we're flushing, right? That way it helps to prevent the poo from, permeating the space. So nursing allergies, we talked about that. Which of these actions would the nurse take to provide a safe anti-infective medication administration? Select all that apply. I like this. We have a varied response. It's always fun. All right. So yes, we always want to check allergies. 2, we want to get cultures when? Before we give the anti-infective. We want to measure peak and trough results. We want to monitor for those white lesions on the tongue. And then we also want to review what's a normal dose range, right? Whenever we're giving a medicine we're not familiar with, what's the normal dose? That's important to know. Okay, moving on very quickly. We're just going to talk a little bit about burns and a little bit of math. So burns are when you have any type of energy that's transferred from something to someone. That energy can be from a lot of different sources. And it causes a lot of issues, right? So you lose your protective function. So let's just say I burn my arm. I don't have my skin to help be that barrier from the rest of the world. It's a risk of infection. It changes sensory function. A lot of times you can damage nerves and you can't feel as well. You're losing a lot of fluid. Big deal with burns that you get dehydrated. Skin regeneration. Most of the time you get a cut, your skin will scab over and heal. You get a big burn, your skin's not going to be able to grow over and heal like it normally would. And then your secretory and excretory function is impaired. So like you won't have like the ability to sweat or things like that from that burned area of your skin. You also have a systemic response. So if you have large burns, you have increase in capillary permeability, which means that how normally we have fluid and electrolytes and things that shift between our cells, it just gets all dysregulated with a burn. You lose your intervascular volume, which means all the blood and whatnot that's in your vessels, it kind of goes out and it is like leaking out into those other areas. So you don't have as much fluid in your blood or in your blood vessels, which means what's probably going to happen with that pressure? It's going to go down. You're going to have a loss of your blood pressure. Because of that, cardiogenic output or your cardiac output is going to go down as the pressure goes down. You can also go into what's called hypovolemic shock, where you just don't have enough pressure. Your platelets aren't going to work as well. And then leukocytes and platelets aren't going to aggregate or maybe like clump together like we would like them to. So it just, your whole system just goes kind of haywire when we have burns. You need a lot of like metabolism or a lot of nutrients, right? Your body is like, hey, I need a lot of building blocks to build back up. And so catabolism, like you're breaking down good things you already have built up to go help repair other pieces like the burned areas. Sometimes you can have hyperglycemia from stress response. Your kidneys, all of a sudden they're like working in overdrive and they might have a little bit of damage. Pulmonary damage. A lot of times with burns, if somebody is in a building that's had a burn, and maybe they're not burned on their body, but if they're breathing in a lot of smoke, that's an area that could be damaged that we don't even see. So it's really important if we have somebody that had a lot of smoke exposure, we're making sure that we don't forget about their lungs, because that can be an area that actually gets burned by the smoke and heat that we can't see. So we talk about when you have somebody that is burned, we use the rule of 9s. So what that means is for an adult, your arms are each 9% of your body. Your legs are twice as much. So 9 plus 9 is 18. So each leg would be 18. Front and back,
also 18, so kind of like twice as much as 9. Your head, so head and neck, that's another 9. And then I think you get 1% for perineum, man or female. It's kind of similar in kids. I'm gonna focus on 9s for adults, but kids as well, they both have 9 for their arms. It's 13.5 for legs, and then 18 front and back, and then they have 18% for head. Just because as kids, you know, think about like toddlers and whatnot, their heads are bigger, so it's more surface area. If I ask you anything, if when we're talking about it, I'm really gonna be referring more to adult rule of 9s. That's an easy way of knowing the percentage of body that's burned.
Let's say we have a 55-year-old woman who's burned with hot water over her anterior trunk and her right anterior thigh. What is the approximate percentage of that burn? So think about the rule of 9s, anterior trunk and right anterior thigh. How much do we think that could be? I know this is a math that's kind of different, right? All right, the correct answer is 23%. Because, and I think I even put it in here too. There we go. So the anterior trunk is 18. And remember the leg is 18 altogether, but it's just the anterior thigh. So really it's only about 5%. It was a critical thinking question, yes. So when we use that, we say it's about 23%. So it's just a way of kind of looking at it. Okay, which type of burn is going to involve the muscle and bone? Muscle and bone. And yeah, full thickness burns. So partial thickness, kind of superficial. Pardon me. There is partial thickness, superficial, and then partial thickness, deep. And then there's the full thickness. I've got some fun pictures. So here's partial thickness, which this is gnarly, right? But you can see this is just the superficial. It's the outside area of the skin. Really dang painful, right? But it's not deep beyond that up the first layer of the skin. Now, this is partial thickness, but where you have deeper. You can see how it's deeper in the skin. In fact, a lot of the skin at the top layer has burned totally away. Then we can move on to full thickness, and you can see where it's even deeper, especially down in here. Like we just got rid of a lot of those protective areas. Not really fun. Excuse me. So how do you get burns? A lot of different ways. It can be directly from a flame. It can be contact, maybe stovetop, right? Scalding, that's with hot water or some sort of hot liquid. Chemical burns, right? Exposure to some chemical force. Electrical, and then radiation. So, question, which type of burn should you overestimate the percentage of injury on your initial evaluation? I know the ones of you who forgot to read the chapter on burns are like, I don't even have a clue. It is a short chapter on burns. And if you guys look in my weekly, the module overview page, I do give you specific pages to read. So I don't say read the whole chapter. I really pare it down. So burns especially is short. Please just look over those few pages. It's got good information. All right. And the correct answer is electrical. And I want to make sure I said this correctly. Oh, I don't think I did. Okay. Well, the reason why is because when you have electricity that enters the body, it takes a path of least resistance, right? So it's going to follow your nerves, right? Those are usually the easiest pathway for it to travel. But it can also go through like bones too, a little bit slower that way. So you can have actually damage to your bones and tissue because the electrical current is going slower through those areas. So you want to monitor for injury afterwards. So what do you do if you have a patient who comes in with a big old burn? Well, you're always going to follow your ABCs with any type of injury, right? Want to make sure let's stop the burning process, right? So they still do stop, drop, and roll. Feel like that's but anyway, somebody is burning, you know, don't run around.
right? Get a blanket, get a jacket, put out the burn, whatever it is. If it's just general information, if you're in the kitchen, you have an oil burn, what do you put on an oil burn? Smother it. Don't ever put water on an oil burn, that'll make it get worse. You always wanna smother it, so put a lid on, or I've seen people like throw flour or something, just like smother that, don't put water on it. Stop the burning process, means if somebody, especially I think of scalding, if they were dipped in like hot water or something, you wanna run that under cool water or apply something cool, because it's still superheated those tissues. So you wanna cool them down so it doesn't continue to burn and kind of bake whatever area was burned. You don't wanna do ice, you just wanna do cool, like tepid to cool, but not, yeah, definitely not ice, that would not be appropriate. You wanna stabilize any related injuries. Unfortunately, patients who have massive burns often have big injuries too, fractures and other things. We also are gonna give them IV fluids. Remember I said with burns, you lose a lot of fluids. You're always gonna be giving patients fluids that have burns. And also pain control. Burns are so painful. I burned my pinky on my curling iron and I wanna cry about it. Like, I can't imagine like the rest, like having these massive burns. So on the acute stage, you wanna make sure it's clean, debride it, get off any like hard tissue, things like that, and put a dressing on it. We wanna prevent infection, so really gonna be keeping very clean. A lot of burn units are very specific about don't bring in flowers. Nobody who's been ill can come in. There's a lot of precautions to protect these patients because they're high risk of infection. Might have skin grafting, so if I burn my arm really good, I had a friend who in high school, she took her, I think it's your radiator cap that like can kind of cut the steam. She burned her whole arm, like just massively, which that would be what percent? It's this right here. Posterior.
5%.
Well, if nine is the whole arm, and it's half and half. Okay, just checking our math. But she had to get skin grafts and they took skin from her thigh and put them on her arm because it was such a bad burn there. We want to monitor for complications. Oh gosh, we're almost done. Okay. Graft. One thing I want to make sure we know about psychosocial care. Some of these people with burns, especially if it's on your face or a large part of your body, it can be very mentally, you feel different, you look different. There's also with contractures, right? A lot of times we think about letting people be comfortable, but with burns, they're going to, like, I like how it shows, it's going to pull back because extension is going to be the most uncomfortable. Extension is when you stretch, right? Burns are tight. The skin heals very tightly. And so they can often heal up very tight. So these patients, we've got to make sure we're teaching them, no, you got to do these exercises. You have to do things so that you still have mobility, because what's most comfortable and staying kind of flexed up is going to end up giving you contractures. Also, a lot of itching. Oh, I didn't have it in here. So just know itching is a big deal, especially for kids. Sometimes they'll put them in bodysuits and things just to help with the itching, because that can disrupt this cleaning of the skin or healing. Okay, that was all. Good luck, you guys. Make sure to fill out. I don't have a KWL. Okay. I will put the KWL right now into Canvas.
Yes.
Good luck on your pharmacology test. I believe you are all capable of doing really well. Good luck. Take some chocolate or mints if you need for snackies later.